Good evening, everyone, and a very warm welcome for today's MedTalk digital session. I am Adafshi, your moderator for this program. We are delighted to have you with us today for yet another insightful session. Today's session is on a very important subject managing hypoglycemia in real world practice. What every doctor must know. Hypoglycemia is a common yet often underestimated challenge in diabetes care, and today we aim to simplify its management and discuss practical strategies that every clinical should be aware of. To guide us through this, we have with us Dr. Arun Raghavan, Director and Consultant Diabetologist at Dr. A. Ramachandran's Diabetes Hospital in Chennai. Dr. Raghavan is an eminent diabetologist with vast experience in clinical practice and diabetes management. It's truly an honor to have him with us today. Hand over it to you, sir. You can continue. Thank you. Sir, you are not audible. So your mic is mute, I think. Sir, your mic is mute. We can't
We
hear
can't,
you.
we can't, we can't.
Are you able to hear me now?
Yeah, sir. Now it's fine. Thank you.
Great. Thank you. Thank you so much. Thank you for having me here yet another time. I would like to take the opportunity to also thank the IGCP group for inviting me and also continuing this education program for a number of years now. As rightly introduced, I'm going to deliberate on hypoglycemia today. Hypoglycemia is something that we are all cognizant of. We know what it is, and we've learned that the flip side of intensive glucose control is also patients landing up in hypoglycemia. We've learned from the landmark glucose lowering trials such as the accord that patients, when they land up in hypoglycemia, it is so detrimental that the macrovascular complications, cardiovascular mortality actually increases, right? So that perhaps has been an impeding factor for us to not only initiate certain intensive therapies, but also when we want to up-titrate our medications in hot pursuit of getting the desired HbA1c target less than 7, right? So when all do we have to worry about hypoglycemia? Obviously in type 1 diabetic patients, because in type 1 diabetic patients, the ammunition that we have is only insulin, isn't it? So whenever we use insulin, there is always a potential chance of hypoglycemia, right? I'm going to touch upon type 1 too. Type 2 diabetes, of course, the larger spectrum of patients where we do have certain agents, we are blessed perhaps with certain agents at this point in time, such as the incretin-based therapies, the SGLT2 inhibitors, and of course, we have metformin and so on and so forth, which preclude patients from hypoglycemia. No? So it's something that today we have the bandwidth to actually reduce the patient's blood sugar, keeping them devoid of hypoglycemia for a type 2 diabetic patients. That's why it is imperative that we use these agents as explicitly recommended by professional societies before we move on or intensify to sulfonylurea or, for that matter, insulin. Work study on hypoglycemia itself in patients about how much debilitating it is and the cost of hypoglycemia. Because one episode of hypoglycemia actually sets them back emotionally, There is a cost that is entailed because when patients come with severe hypoglycemia, there is correction, there is observation, there is IV infusions, there is loss of work, so on and so forth, right? It actually off tracks them. And then the fear of hypoglycemia can be so severe that they would actually not have intensive glucose control, or they might actually relax or tend to neglect glucose control. And that's so important hypoglycemia is in any patient's journey with diabetes, be it type 1 or type 2. So, what is hypoglycemia? The recommendations or the guidelines say that hypoglycemia is below 70 milligrams per deciliter. However, patients can be even symptomatic at 80s, 90s. So it is also essential to understand each patient's individual profile and perhaps set the baseline threshold accordingly. Because a patient whose HbA1c has been over 8, 8.5, 9 for quite some time, when we bring it to 6 or 6.5, or at least the glycemic numbers, if we have it very intensive control, there are chances that the patient may feel hypoglycemic symptoms even at 80s or 90s, right? That's something that, based on individual profile, we could probably set a higher threshold limits, even 80s, 90s if patient is symptomatic. Keep them around 100, make sure they are not symptomatic. Because once they are symptomatic, they're going to grab something, eat something, they're only going to increase the blood sugar. And we know that glycemic variability, right, which is low, high. Low, high is even more detrimental to the patient because of increase in oxidative stress that tantamounts to complications. So if patient is symptomatic even at 90s or hundreds, please make sure that they don't feel symptomatic. Right? Take them gradually to better control, because they would do defensive snacking, they would eat, they would raise the blood sugar, which is actually not going to be good for them. Right? And any blood sugar less than 54 is extremely severe form of hypoglycemia, where more often than not, they may need some external help, right? You may, patients, attenders or relatives or their close ones, friends would have found them, and there would be a rescue attempt done. It could be, feeding them with sugar, or possibly taking them to a nearby clinic, and then also possibly giving them glucose infusion, so on and so forth, right? And let's quickly recap the basic pathophysiological mechanisms that happen in hypoglycemia. Right? What happens in hypoglycemia? They are the counter-regulatory hormones. The body's defense mechanism is also so profound, so impactful, right? The counter-regulatory hormones are the glucagon, the epinephrine, cortisol, and the growth hormone. So these are the counter-regulatory hormones to insulin, right? So the glucagon perhaps may be the first counter-regulatory, and then comes the cortisol, then comes the catecholamines, and then the growth hormone. Now, when patient lands up in hypoglycemia repeatedly, what happens is there is blunting of the response. So the blunting of the cortisol, blunting of the catecholamines. So what happens? There is a hypoglycemia awareness that would set in. And that largely can be extremely dangerous for the patient, because patient may be having repeated bouts of hypoglycemia where they may be completely unaware, and we know how detrimental it could be to their long-term complications, and including their cardiovascular system. And that is why in any patient who is on good glycemic control, who's probably on multiple doses of insulin or sulfonylurea, it is essential to use CGMS now and then, so that we get deeper insights to the patient's glycemic pattern. And the other important factor you can also consider is, I know patients do have sometimes cardiovascular diseases or ischemic heart diseases where they may invariably be on beta blockers. Now, beta blockers can sometimes mask the response symptoms, because the increase in heart rate, right, driven by the catecholamines, due to hypoglycemic symptoms, the adrenergic response, the tachycardia response in heart rate, that can sometimes be mitigated by the use of beta blockers. So the glycopenic symptoms or the adrenergic symptoms can sometimes be masked by the beta blockers. So patients who are on beta blockers, we have to be much more vigilant, especially those, as I mentioned, who are on secretagogues such as sulfonylureas or on insulin, where there is potential risk of hyperglycemia. So patients who are on beta blockers and or on secretagogues and or who are on insulin, we have to be more vigilant. Of course, frail patients, elderly patients, patients who are having renal insufficiency, the drugs are likely to be half life is likely to be prolonged. Right, any drug is going to work for much longer duration. Yes, we could use a DPP-4 inhibitor, metformin, but in not all patients it would be suffice. Invariably, we'll be resorting to sulfonylurea or insulin. And at that point in time, the drug's action is so prolonged that again it could land up in hypoglycemia. So again, these patients, we have to be quite vigilant. Patients who are fasting, particularly the sections of different communities for religious fasting, I generally advocate that if your A1C is in sync with agents not resulting in hypoglycemia, like a DPP-4 inhibitor or metformin, I would encourage them to continue their fasting. But in patients who are on multiple doses of insulin or sulfonylurea, I generally advise them to possibly refrain from fasting, because this either we have to step down on our therapies, we have to switch our therapies, which could be a challenge itself, because it is only going to worsen the glycemic status over that entire period of fasting. So this is something that I generally tell my patients. Just to understand the typical case scenario, here we have a 60 middle-aged gentleman with the twice daily pre-mixed insulin and glimepiride. And this gentleman had nocturnal sweating, confusion. Now, pretty straightforward, right? He's on sulfonylurea and he's glimepiride metformin combination and pre-mixed insulin, twice conventional insulin. So we'll have to, how do we handle such patients? Now, the best way is to, step down on the sulfonylurea, because whenever there is a short-acting insulin used, sulfonylurea in combination can increase the risk of hypoglycemia. So we step down on the sulfonylurea, replace sulfonylurea with a DPP-4 inhibitor and a metformin, and probably switch the conventional insulin, premixed insulin, to analog insulins. Or we could even shift it to a basal plus or a basal bolus. Remember, even the analog insulins, only the short acting part isn't truly an analog. The longer acting, the pharmacokinetic or dynamic behavior behaves as a regular conventional intermediate acting insulin. Now, for convenience of understanding, let me quote the brands like the premixed Novomix insulin analog, right? The Novomix 3070, the short acting aspart is truly an analog. Whereas the intermediate acting insulin, the protominated aspart, the PK/PD property of the protominated aspart is pretty much like an NPH, which means the peak, the risk of hyperglycemia is inherently there. And the cost that we are paying is only for the short acting aspart. So there is the risk of hyperglycemia during the other part of the day. Similarly, the homolog mixes, the short-acting insulin there is the analog, whereas the intermediating component is not truly a analog. Although they are mentioned as Novomix analogs or premixed homolog mix analogs, they are only the short-acting component is an analog. That is something that we have to be very aware of. That is why in patients who land up in hyperglycemia, it may be better to independently take the components, have short-acting separately, and have a long-acting analog such as a degludec or the U100 or U300 of glargine. Now that gives you a greater flexibility, because when you adjust the short-acting, you can independently adjust it without compromising the long-acting. Whereas in a pre-mixed insulin, invariably when you adjust one component, the other component also tags along. That's the advantage when you actually have basal bolus, which kind of mimics the human physiology as close to normal. It still cannot exactly mimic, but as close to normal. It gives you such great flexibility to titrate, down titrate, up titrate each of the insulin components. Thereby, you may be able to address the glycemic variability without additional risk of hyperglycemia. So pretty much that's exactly how you have to encounter or tackle this particular patient. And immediate response, of course, I think I'm not going to dwell into this too much, but over treatment should be avoided. That's something that we normally do. Once a patient comes in fluids of 25 ml dextrose is given one shot after the other, where patient's blood sugar goes from 40 to 300, 400. It's not going to be good for the patient at all. As I mentioned, extremes in glycemic variability is only going to increase oxidative stress, is going to make matters worse. So look at the patient's blood sugar after 15 20 minutes after a simple correction, after giving a 15 grams of carbohydrate should also be sufficient in most patients. And individualized targets, I think, in patients, as I mentioned, whose HbA1c, I had another patient whose A1c was about 7.1, been consistently doing well with the sulfonylurea metformin combination. He wasn't on an SGLT2 inhibitor because he had history of recurrent urinary tract and genital infections. The DPP4 inhibitor, he had increase of his pancreatic enzymes, which also precluded me from using these enzymes. So he was on a sulfonylurea metformin combination. He was doing reasonably well. He had about 7.1, 7.2 HbA1c whenever he comes for a blood glucose test. And he was happy, I was happy, until one day when I asked him, do you ever get any hypoglycemia? He said, no, I'm extremely comfortable. I'm absolutely fine. Until then, when I probed him and I asked him, is there any time when you have any excess hunger, or do you think that you get angry at some times, or you frantic in chase of food? He said, yes, doctor, that happens before my lunch. Every day, if I miss my meal 1:15 or sometimes even 15 minutes before my meal time, I start sweating. I become so hungry. I said, that's what is hypoglycemia all about. That means you've been having this for quite some time. And to validate it, to just make sure, I placed a CGMS today, as we are blessed with these technologies. So I used a CGMS, and it showed me in almost every other day the patient was landing up in hypoglycemia before his lunchtime. So the lesson was that any patient whose HbA1c is reasonably good, who's on a sulfonylurea or who's on insulin, I generally ask them as a part of my routine whether they've been encountering hypoglycemia. And in case if they say no, I actually enumerate the symptoms. I ask them, probe them even deeper, not just at one point in time. At every review, whenever a patient is on insulin or sulfonylureas, I kind of ask them whether have you had hypoglycemia or not. Enumerate the symptoms and make sure, and that vigilant, particularly in patients whose HbA1c is at a lower threshold, where there is always a potential risk of hypoglycemia. And then I switched this patient to a higher dose of metformin, tapered the sulfonylurea as much as possible because I wasn't able to use any other agents in the such. And then I was able to wean him off or prevent him from actually landing up in overt frank hypoglycemia. And then to finally also conclude on type 1 diabetes, I wanted to talk on type 1 diabetes. I think I've mentioned about CKD status. Type 1 is perhaps the most challenging form, especially when they're many years into their journey. There could be brittle diabetes. Some of them do master the craft of adjusting the insulin on their own. However, it is not like type 2 where we have so many numerous plethora of agents today in our bandwidth to actually control a patient's blood sugar without much risk of hypoglycemia, because the landscape has completely changed, as we are all aware of in type 2 patients with diabetes. But type 1 is not the case. It's still insulin, the gold standard, and insulin is the only ammunition that we actually resort to. But however, in patients who have higher risk of hypoglycemia, particularly in those patients who achieve the time in range, but the risk of the time below range also is significant in their CGMS, I think one technology that today we can actually resort to is the sensor augmented pumps. There are multiple options today available globally, but in India we have the Medtronic 780G. This is a game changer because what the pump does is, of course, it has machine learning and artificial intelligence. The sensor augmented pump, which means the sensor checks for the blood sugar every 5 minutes, which means about 300 times a day, almost 300 times a day. It checks a patient's blood sugar and adjust micro boluses accordingly, right? Now we could give 3 to 4 times insulin. The insulin pump gives every 5 minutes, and every 5 minutes it recalibrates and gives different kind of dosing and keeps the patient's blood sugar between 100 to 180. So it's an automated pump. Only the boluses during the mealtime patient needs to feed in the carbohydrate quantity, but even that the sensor overtakes if there's a error in patient's data entry. So the overrides and overcomes the data error in case if there is, and as it checks every 5 minutes, it starts correcting the patient's blood sugar and auto adjusts. So the micro bolus is given every 5 minutes to make sure patient's blood sugar is in good bandwidth, and you can also personalize targets for each of your patient. You could have a temporary target of 150 when patients are exercising. Otherwise, in most patients, you can have either a target of 100 or 110. And in majority of my patients, where time in range is over 95%, that can be impossible for a human intervention, whether medical professionals or how much of a team that we have, we will not be able to achieve that kind of time in range without risk of hyperglycemia. As we know, the sensor augmented pumps also suspends the insulin release whenever there is risk of hyperglycemia. It predicts hyperglycemia in about 4 hours because it understands the patient's blood sugar, how it is likely to drop. So that's the kind of algorithm that is written for these kind of tech devices. Of course, these are expensive, but they are game changers. And today, that is the standard of care for type 1 diabetes if you want to keep them in good time and range without any risk of hyperglycemia. With this, I'd like to conclude my talk. Thank you very much.
Yeah, thank you so much, sir.
Sure.
Thank you so much, sir, for that enlightening and thought provoking sessions. We will now take a few questions from our audience, and I
Yeah.
request all participants to drop their queries in the questions also, and I'll read them out for sir. So, the first question is, what are the most common causes and risk factors for recurrent hypoglycemia in diabetic patients or in insulin or oral hypoglycemics?
Yeah. In patients, as I mentioned, who have secretagogues or who are on insulin, who are on good control, there are two common reasons. One is that they are overtreated by clinicians. We may be giving them more drugs than actually required, right? So we have to uh, understand each patient's profile, say 5 years of diabetes or 10 years of diabetes. Sometimes we can also do the C-peptide insulin assays, how much of insulin the patient is producing, patient's pancreas is producing, and that will give us a good reference range on what are the oral anti-diabetic agents that we can play around with. And if there is good beta cell reserve, we can actually have a very small dose of sulfonylurea which can gently work on the pancreas without squeezing the pancreas and indifferently releasing insulin, which obviously would land the patient in hypoglycemia. So obviously we'll have to look at from our perspective whether we are over treating the patients. That's something that we should be extremely aware of. That I think the factors to consider is, of course, the patient's threshold of A1C, whether they are landing up in hypoglycemia even after eating on time. If they have good C-peptide reserve, if they are in short duration of diabetes, then possibly we'll have to take 2-3 steps back, taper the medicines down. The other common encounter that I see in patients would, of course, be neglecting to eat on time. Today, patients in their prime age group, they end up working all the time. They may have a delay. They may not. They may take insulin and they may forget eating on time. All sorts of things can happen. I think patients who are on metformin or somebody who's on very basic minimum medicines is okay, but patients who are on multiple agents which are likely to produce hypoglycemia, I think we have to educate our patients as much as possible to make sure they eat on time, to take the drug which coincides according to their meal time. Like an insulin of a conventional insulin should not be more than 30 minutes after a meal, before a meal. If patients take a meal 45 minutes after the injection, they are likely to land up in hypoglycemia. Similarly, analogs can be about 10 minutes, not more than 10 minutes. Like that, I think that kind of education needs to be done. So these are the common factors that we generally encounter in a patient's journey.
Okay, thank you so much for the answer, sir. I hope you did justice with the answer, sir. So the next question we received: how has continuous glucose monitoring (CGM) improved the detection and prevention of hypoglycemia?
Very much, because the new Libre that is with us right now is accuracy is even higher than its predecessors, because earlier CGMS devices, I think the hypoglycemia risk, they were not that specific. Um, the specificity kind of dropped down. The specificity is better between 80 and 140 blood glucose levels. But the newer CGMS devices are more accurate even at lower sugar levels. And that has been a game changer, because today we can look at nocturnal hypoglycemia. We can understand nocturnal hypoglycemia. There is no way that we can ask our patients to check every hour during the night. Today, that's possible. So the CGMS have been two game changers. And as professional societies recommend, I think every type 1 diabetic patient should have a CGMS done at least once a year. And every type 2 diabetic patient, again, who's on secretagogues or on multiple doses of insulin, also can do once in a year, if not more, to understand their glycemic pattern.
Thank you so much for the answer, sir. I hope you did justice. So the next question we received: are there specific insulin regimens or newer anti-diabetic agents that reduce hypoglycemia risk significantly?
That's an excellent question. Of course, I think as we've been evolving with insulins, if you look at the basal insulins, what we look at from a basal insulin is not even potency. We what we expect from a basal insulin is not fast abrupt reduction of blood sugar. What we expect is a very flat, smooth profile, peakless profile, where the risk of hypoglycemia is lower. So on that note, if you've seen, the first basal insulin was the NPH, and from NPH there was this glargine, which was probably a benchmark gold standard basal insulin for a couple of decades, glargine U100 or the Lantus, for convenience of understanding. That kind of made it very simplified for many clinicians around the world to start off basal insulin, titrate. The risk of hypoglycemia was 50-55% lower than its predecessors. Similarly, that's the kind of shift that has happened now in the last about 5 to 10 years, when we have the U300, the glargine's next version, or the engineered deglutec. Both these insulins have such flat profile, such peakless profile, where they get the job done, get the blood sugar under control without much risk of hypoglycemia. So hypoglycemia risk has been largely mitigated by the newer generation basal insulin analogs.
Thank you so much for this brief answer, sir. So, as I can see, there is only one question is left, sir. So, the question is, what precaution, what precautions are necessary for hypoglycemia management in patients on SGLT2 inhibitors or newer therapies?
SGLT2 inhibitors do not cause hyperglycemia. They are very safe agents. They are approved for even patients without diabetes, in patients with CKD, in patients with heart failure, so on and so forth. So they have absolutely no risk of hyperglycemia. Whereas in other patients, whenever they have hypoglycemia, I think if they are just symptomatic but with sweating and excess hunger, best would be any simple remedy at home itself. Giving them a simple wraps of biscuit or a cookie or a chocolate or a candy to eat with. That itself will settle them. But after that, we'll have to tell them that can be a first rescue. But after that, please get back to the clinic or to your doctor so that they down titrate the medicine accordingly. So we'll have to educate the patients on correcting hyperglycemia in case they experience, but we also have to educate them to reach out to us after the patient's hypoglycemia gets corrected. Of course, if it is so worse, then obviously then it becomes more of a clinical team's prerogative, where that's done by each clinic's protocols.
Okay, thank you so much for the answer, sir. So I hope you did justice with all the answers, sir, and we look forward having more such interesting sessions with you in the future also, sir. On behalf of MedTalks and IGCP, I sincerely thanks to Dr. Arun Raghavan for his valuable time and expertise today. And thank you all to attendees for joining us. Stay tuned for more such engaging MedTalks digital CME sessions and with leading experts in healthcare. Thank you so much, everyone. Thank you, sir.
Thank you very much. Have a good day. Bye.